we had the opportunity to study the first-degree relatives of rheumatoid arthritis patients in First Nations communities to understand how rheumatoid arthritis starts, potentially with a view to thinking about prevention measures, which, as you know, preventing autoimmune diseases now has become an important global topic of interest.
That's Dr. Hani El-Gabalawy. He is a professor of medicine and immunology, a senior clinician scientist, and endowed rheumatology research chair at the University of Manitoba. Dr. El-Gabalawy has also established a unique cohort of at-risk First Nations family members of RA patients who are being followed longitudinally for the earliest evidence of RA onset. He's our guest on this special Indigenous health-focused episode of Around the Room. Hi, I'm Daniel Ennis. Today, I'm handing over the host mic to my colleague, Dr. Brent Ojeda. Dr. Ojeda is a clinical assistant professor of rheumatology at the University of British Columbia. He is passionate about health equity and Indigenous health, and has established outreach rheumatology clinics to the Carrier-Sekani First Nations, as well as the downtown east side in Vancouver. He is the co-lead of the RTVS Quick Reply Pathways, which provide video specialist advice to rural BC family physicians. Over to you, Brent and Hani.
Hani, welcome to the Around the Room podcast. It's lovely having you here.
Thanks very much, Brent. Appreciate the opportunity to talk about this very important topic.
Hani, you were invited to speak on this podcast about research that you've done on rheumatoid arthritis in Indigenous communities through North America. For listeners who are unfamiliar with your work, I was wondering if you could give a synopsis of your research on this topic.
My colleagues and I in the rheumatology here in Manitoba have long been struck by the high prevalence, severe disease, and bad outcomes that we see in rheumatoid arthritis in First Nations. And we recognize that this is a complex interplay between genetic factors, environmental factors, healthcare delivery, and so on. And so back more than 20 years ago, we had the opportunity to get some funding from the Canadian Institutes of Health Research to study the first-degree relatives of rheumatoid arthritis patients in First Nations communities, and to try to follow them longitudinally to understand how rheumatoid arthritis starts, and potentially with a view to thinking about prevention measures, which, as you know, preventing autoimmune diseases now has become an important global topic of interest. So we were fortunate to follow a large number of individuals for many years, some of whom developed rheumatoid arthritis, many of whom didn't. And we were able to compare those that did to those that didn't, what happened to their autoantibodies, what happened to their other circulating biomarkers, their symptom complexes, and so on. And it has really given us a important insight, which I should add has been noticed by our colleagues around the world who are trying to do similar things in other populations. And it really has given us a unique opportunity, a window on how rheumatoid arthritis starts in this population.
That's very exciting. So you mentioned a little bit about one of the purposes of this research is to try to find a way to prevent rheumatoid arthritis from even starting. I was wondering if you could tell me a little bit more about that and how far you've gotten with that.
Not as far as I'd like, not as far as any of us would like. But so just a little bit of background. As I mentioned, a lot of international interest in if we can detect rheumatoid arthritis risk early. And at this point, it's based primarily on the presence of autoantibodies, rheumatoid arthritis autoantibodies, anti-CCP and rheumatoid factor, and so on. And then maybe we can intervene at a stage before the disease becomes established and becomes irreversible. I think we're very good at suppressing inflammation now, but I think most of us recognize that the underlying autoimmunity, once it becomes established, is really very hard to turn off, as evidenced by the fact that when you withdraw treatment, in many, if not most individuals, the disease comes back because that autoimmune engine is still there. So the interventions that have been attempted in the international community have centered around things like repurposing RA drugs like methotrexate, hydroxychloroquine, and more recently abatacept, at a stage when individuals have symptoms, aches and pains in their joints, but they don't have swelling and they don't you can't be classified as having RA. And what those studies have taught us is that the disease at that stage can be delayed, but for the most part, it can't be prevented. So we are pursuing a hypothesis that if we go a little further back, maybe even before symptoms develop, at a time when there's only the autoantibodies starting to evolve, maybe we can go back to prior to what I like to think of as the point of no return. Our current interest is looking at using a combination of anti-inflammatory nutritional supplements. We have a nice animal model, a collagen-induced arthritis model, that we've used a combination of vitamin D, omega-3, and curcumin, the active ingredient in turmeric, and used them in combination and showed very effectively that we could ameliorate the onset in the collagen model. So now we're looking at doing some human studies in that risk population. So that's really what we have in mind in terms of intervention. The challenge is how to do broad screening in communities without using up a lot of resources in terms of people flying in and research teams and so on to a lot of remote communities. So we've more recently we've developed a dry blood spot test in collaboration with some experts in the National Microbiology Lab who do this for serology, and where the easy to do on a drop of blood on some blotting paper, and they send it back to us, and we extract protein and detect the antibodies. And that. So we're quite excited about that because it's scalable, and hopefully it will allow our reach to be much further in terms of identifying individuals.
So, Hani, there was one topic that I wanted to cover, and this is the idea of the process of doing research with Indigenous subjects. Unfortunately, there have been a number of negative experiences that many Indigenous patients have faced with researchers, either through nutritional experimentation or other unethical research. And as a consequence, there's oftentimes very well-founded skepticism of researchers in Indigenous communities. I was wondering if you could talk a little bit about how you have established trusting relationships with your Indigenous communities that you've researched, and how doing research with Indigenous communities is different than doing research with Caucasian communities in Manitoba, for example.
That's a very important question, Brent. And so let me start out answering that by acknowledging the fact that we have had a lot of help from our university, which has a particular interest and focus on Indigenous health, and there is the Ongomazan Center for Health and Wellness is really has been very, very instrumental in helping us navigate the path towards doing this properly. And I want to acknowledge particularly Elder Margaret LaValle, who is now well into her 80s. She's the elder in residence for the University of Manitoba, and such an incredibly wise person, and has been with us, engaged in this project for more than a decade, and individuals like her, emerging Indigenous scholars in Ongomazan research. So that's number one. We have an institution that knows how to do this, and in particular knows how to develop agreements with communities, which brings me to the concept of individual consent versus community consent. I think we're all comfortable in human research with the concept of individual consent. You have a consent document, you make sure that the individual understands it, with a translation if necessary, and certainly we do that with all the research that we do with First Nations people. But there's also the concept of community consent, and that takes the form of a community agreement. That's typically, in our case, is an agreement actually between the university and the community on behalf of our research team. And we have a lot of expertise at developing these type of agreements, and which encompass a principle that's quite important, which is that of OCAP: ownership, control, access, and possession. And those principles give guidance to the research teams and to the communities around things like what can and can't be done with the data, what can and can't be done with the samples, secondary use of samples, and so on. These are really important considerations. The other important thing to note about that is that we have individual agreements with each community we work in. We don't have a one-size-fits-all. And one of the communities we developed an agreement with, the chief was a lawyer, and the nature of the agreement very much reflected that. But it incorporates many of the same elements. In another community, the co-author of the agreement with us was a health director. So each community comes at it from a different perspective, and we work with that, and we make sure that the agreements are fully ratified by the community, and that any amendments that are needed down the road because things change, the nature of the study changes, the nature of the leadership changes. We've certainly lived through that, and we have to make sure that we stay connected with the community. So those really are kind of a brief summary of what's needed to undertake research at least administratively, in a First Nations community. But transcending that is goodwill, is trust, and the most important, in my opinion, is showing up. You got to show up in the community. You can't do this by Zoom. You can't do this by virtual means. You have to go with the team and engage with the community. And ideally, for us, we have found that things like annual health fairs, for instance, are a very, very good venue for having a booth focusing on our area of interest and so on. We just had in one of the communities work in Norway House, Cree Nation. It's a where we have to fly in, and we got there. We had a booth last summer, and we were able to pilot our dry blood spot technology, and within 5 short hours, we were able to recruit more than 100 people, 110 people with dry blood spots, and then we're in the process of verifying the results now with more conventional phlebotomies and so on. So the important thing is you have to show up, you have to keep showing up. And then ultimately, if you develop approaches like the one I've just described, where you can make it more efficient, you can work with local research assistants, then things will go quicker and smoother.
That's fantastic, Hani. And I think the idea of ownership and consent and OCAP and whatnot of data is really important. So when you talk about collection of blood samples and spot tests and whatnot, I was wondering if you could just share a little bit more about that and how you manage the blood samples that you collect and any issues that have arisen from that.
Yeah, I think that these are, as you probably know, the perspective, First Nations perspective on blood samples is they're sacred. And so simple things like after you've had the samples to do your study for X number of years, culturally sensitive ways of disposing of the samples are important. And we've had great guidance from elders like Margaret LaValle as to how this is best done, and so that's important. One of the areas that really has been quite challenging is the area of secondary use of samples and secondary use of data, and who can collaborate and who can't. And I think that was at the heart of the red flags you raised at the beginning of the conversation. Samples and interventions were undertaken that people did not consent to, and communities did not consent to. And I'll give you an example of this in a very well-meaning way. Back more than 10 years ago, almost 15 years ago now, when we were working in a certain community, and we had gathered samples, blood samples, looking, and we're interested in periodontal disease and its relationship to onset of rheumatoid arthritis and risk of rheumatoid arthritis. We went up with a dental hygienist and we did some systematic examinations of the oral cavity and so on. And we took some blood samples. And the community we were working on is a community called St. Teresa Point. Then fell to a very staggering epidemic of H1N1 influenza. As you recall, this was running rampant around 2009. Shortly after that, I was spending a few months on sabbatical in Leiden, working on some analytical techniques that we were developing, and I was approached by collaborators, friends really, at the National Microbiology Lab, who knew that we were working in St. Teresa Point, and they were very interested in trying to sort out whether the risk, what were the risks for developing severe H1N1 infection in the community, because a lot of people were ending up in the ICU and they were really getting quite sick. And so I still remember a very fateful conversation with the health director there, we had become good friends. And I called him from Europe and I said, what do you think of this? I've been asked to do this. The individuals not consent to this. This is a completely different use, but it's something that's compelling for the community. And the answer was predictable. I mean, if it's going to help our people, please do. And, he kind of discussed it with the chief and council and so on. And we did. And we made the samples available for that. And we obviously approached the ethics committee as well, make sure that. And then a number of years later, the legal folks at our institution said, "Wait a minute, did you guys get proper consent to do this?" And so a number of red flags were raised, not by the First Nations people, but by university staff and so on. So it really is a very tricky situation. And when you have access to samples that you had for one purpose, and then even though the secondary use of those samples was compelling and well-meaning, and you got all the permissions you needed, it's still a gray zone.
I do think that a lot of your research is clearly well-meaning and clearly intends to benefit the Indigenous communities that you're working in. One thing that has come up in the past few years is the challenge associated with negative stereotypes being reinforced by prevalence studies. And I guess the example that's come up recently is, studies looking at increased prevalence of cardiovascular disease and diabetes in Indigenous communities throughout the world, and how these, to a certain extent, can reinforce negative stereotypes amongst healthcare workers against these individuals, with the idea being, perhaps if only they ate less sugar or did this or that or the other, they would be better. How do we do these types of studies without reinforcing stereotypes?
That's a challenge. I think you wouldn't be bringing this up if it wasn't a challenge. On the other hand, I think we have tried to be as factual as possible in untangling. When we talk about environmental factors, we have tried to be as concise as possible as to the environmental factors that are potentially contributing to the risk of RA, and things that have been well established around the globe, like cigarette smoking, are clearly in play in this particular situation. I already alluded to the periodontal disease, which has had a strong link in many populations with risk of developing rheumatoid arthritis and the autoantibodies. So, and then the other part of that equation is the genetic factors, and we really have been leaders in understanding the immunogenetic risks, the unique immunogenetic risks in this population for rheumatoid arthritis. And you may be familiar with our studies looking at particularly an HLA-DRB1 allele called 1402, which is unique to the First Nations population, Indigenous North Americans. It's virtually seen nowhere else in the world. It encodes for the shared epitope sequence that we're also familiar with. But it does it in a very unique way, and we published some data showing how that's done in terms of how peptides are oriented when they're presented to T cells with this allele. And the interesting thing when you look at this risk is you see that this 80-90% of the background population actually has this. So it's striking, and it's not just one region. It's the Pima, it's the Tlingit in Alaska, the Pima in Arizona, the Chippewa, the Yakima, the prevalence of 1402 is striking, and it really made us think that it must have played a role in somehow providing an advantage to survive possibly colonization with a barrage of infectious diseases, anywhere from TB to measles to what have you, smallpox. We actually tried to start thinking about doing some work on it. It's really quite difficult, looking at pre-colonization scaleal remains and so on. So it's quite interesting trying to untangle gene environment effects. But you're going back to your original question, which is how do you avoid stigmatization? I think that the partnership that you have with the community, the partnership that you have with elders that will help you navigate that important challenge is quite important. The other aspect of this is providing care, rheumatological care in the community at the time you undertake a study like this. And we've been very fortunate working with Dr. David Robinson, who like yourself, has done a tremendous number of outreach clinics all over Manitoba, all the way up to close to the North Pole. And these have been enormously beneficial to the community. And then that in itself is quite helpful in recognizing the unique aspects of the disease and its phenotype in these communities.
Are you seeking a community dedicated to advancing rheumatology care, education, and research? Welcome to the Canadian Rheumatology Association. At the CRA, we're more than just an association. We're a community of passionate professionals united by a common mission to promote the pursuit of excellence in arthritis and rheumatic disease care, education, and research. With us, you're not just a member, you're part of a dynamic community dedicated to supporting you in every step of your journey. From career advancement to patient care, join the CRA today and experience the benefits. Enjoy organized networking, invaluable advocacy initiatives, curated training and education, grant opportunities, resources for clinicians, students, researchers, allied health professionals, and so much more. Together, we'll shape the future of rheumatology in Canada and beyond. Join our community by visiting rheum.ca and become a member today.
When you mentioned a few minutes ago about genetic mutations and genetic susceptibility for rheumatoid arthritis, I couldn't help but think of those studies that found an association with the emergence of MEFV genetic mutations for familial Mediterranean fever, and associating that with the emergence of those genes with survival benefit in the bubonic plague. Is that a thing that can be investigated further for RA susceptibility genes in indigenous populations?
Absolutely, it could, and it's just been tantalizing me for many years. But I just don't have the toolkit, and I think I alluded to that to be able to address this in a systematic way. So I'm looking to somebody with less white hair to be able to take on the challenge. But it really is, and as I say, we've got data now from multiple indigenous North American populations showing the very high prevalence of this, and having untangled the mechanism by which antigen is presented with this HLA allele, I think that this is the ripe for the taking, so to speak, for some smart person that could become well connected with multiple communities and start working with why it is so prevalent.
Absolutely. I mean, I think, if there is a pandemic event like the bubonic plague in the indigenous communities, it would be colonization and the, destruction of 80% of the population as a consequence of that. But who knows? I mean, I think we're wandering into a data-free zone, I suppose.
No, yeah, I think very much so. I mean, just to amplify on that a little bit, we actually had a colleague who was a Mexican scholar, and she had access to skeletal remains that were unearthed at the time when they were digging the tunnel for the subway under Mexico City, and they were pre-colonization, and we tried our best to come up with some approaches around this, and it's simply, and as I say, it's just beyond the skill set and the focus of our particular research team. So, but it's an intriguing question.
Hani, it's been a pleasure talking to you. I thought we could finish off with one final question, which would be, are there any other best practices, pitfalls to avoid that you can think of imparting upon the audience after your career of doing research with Indigenous populations?
Well, I think there is some pitfalls. The number one pitfall, I think, is being in a hurry. As researchers, we spend our time, if you pardon the crass expression, begging for money, and that's and then there's deadlines and timelines and publications and building trusting relationships with communities simply takes time. So a big pitfall is trying to rush through and get things done in a timetable that is just not suited for developing those kind of relations. Number two is doing things that what has been called fly-by research, which is you go in, you do your thing in the community, and you come back out, and you get your samples, and that's viewed with quite a bit of contempt, that this is a form of colonization. So I already mentioned having a reciprocal relationship based on providing clinical care, and the one thing for us that has been exceedingly successful has been working with the local radio stations. And we have these, where everybody listens to the radio station. It's just in contrast to putting together an evening event where you talk about rheumatoid arthritis and 3 people show up. The radio station outreach is really very, very effective. We've had multiple call-in shows where individuals anonymously will call in and say, I have this or I have that, and what's the weather affect this, and so on. And we ultimately get a lot of the same questions again. But every time we go up, we've had one of these radio engagements, and I can't emphasize enough how important that is in engaging the community. I think that one of the traps that we have kind of fallen into is a trap where there's a tug of war between leadership in the representing multiple communities, both regionally and nationally, and leadership in the communities themselves, and the trap of thinking that getting everything, all the I's dotted and the T's crossed with large national and provincial organizations absolves you of any responsibility to actually interact with the local communities. That's a big trap. And each one of these First Nations communities, as you know, is unique, is a unique nation in itself. And we have to recognize that, and we have to work with them individually. And each relationship is important and takes a long time to develop.
Hani, it's been a pleasure speaking with you. I look forward to seeing you at the next CRA meeting.
All right. Thanks a lot, Brent.
Thanks, Brent and Hani. That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag our Twitter account with your question at CRASCRroom. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. I'm Daniel Ennis. Thanks so much for listening.